And today we're going to talk about the assessment of the left ventricle, both from a structural and a functional point of view. Before we go on, just reminding everybody that if you have any questions, you can submit them through the web by going to paulev.com and then entering DeBakey and respond to the activity, or by text by texting DeBakey to 37607. All right, well, assessment of left ventricular function is one of the things we do commonly every day in the echo lab, and it's one of the main reasons that echoes are ordered. The outline of today's lecture is first a little bit of imaging tips. We're going to then discuss chamber dimensions, measurements of volumes and ejection fraction, some of the 3D techniques, and of course the newer kid in the block, which is left ventricular strain. And finally, just a few of the newer developments and applications for machine learning and artificial intelligence, which probably are going to have a major impact in the future. So these are the common views that we used for assessment of LV, parasternal long and short axis, and the apical forward and two-chamber view. Everything that I'm going to discuss regarding measurements can be found in this wonderful guidelines document by the American Society of Echo in 2015. So let's start with this case. What do you think is the ejection fraction? Would you say is better than 50% or less than 50%? To be honest, if I were to look at this, I would say probably it looks like it's better than 50%. Well, look at this picture now. What do you think? Is that a good EF? Certainly not. It's the same patient, done seconds apart. You can see the EKG looks identical. And what this is a wonderful example of foreshortening. And foreshortening is the Achilles tendon of echocardiography. Echo is a tomographic technique, and therefore when we are imaging the left ventricle, whatever view you are doing, you would like to be slicing the heart through the center of the cavity to get the best images. However, if you foreshorten and you are imaging at one of those extremes, then the cavity will look smaller and the function will appear as better. Foreshortening can happen in any view, particularly in the apical views. And in the apical views, we have another type of foreshortening, which is not having the transducer right at the LV apex. So that if you're at the apex, you should have a 4-chamber and a 2-chamber view with the apex pointing pretty much towards the transducer. However, quite often the transducer is placed at the apical impulse, which is not the real true LV apex. The true apex is further down in the chest. If you do that, you're going to get an image. You get a 4-chamber, but notice how this long axis looks short, and importantly, the apex in the 2-chamber view is out of plane. It's not pointing towards the transducer. That's a very good clue to know that you are not at the real apex of the left ventricle. The other big problem that we have with patients who are either breathing very hard or after cardiac surgery is translation, where the heart actually moves within the chest. So in diastole, you may have a perfect cut through the center of the cavity, but in systole, the heart has moved, and now you're foreshortening. So that can be a problem that you can recognize. If you look at the center of the cavity, you will see that that center of the cavity has moved from diastole to systole. This is a table taken from that ASE document with some of the tips that are given to try to get a good acquisition for measurements of the left ventricle. Minimize translational motion. If patient is breathing hard, try to have them breathe a little more quiet, or maybe hold their breath for a few seconds. Maximize your image resolution, which is just good technology. Avoid the apical foreshortening, as we mentioned. Maximize endocardial border, sometimes using, today we use harmonics a lot to do that. And as you see later, contrast can be very helpful. Maximize endocardial borders and properly identify diastole, and systole. Because of the importance of placing the transducer at the apex, all echo labs nowadays have the examining table cut with an area where the transducer can be moved further down to find the real apex of the left ventricle. When you do portables in the ICUs, this may not be available, and that's one of the challenges we have with portable studies. Before any measurement is made, first step is to select the appropriate image for making that measurement. It should not be the first picture that one sees when starting a study. So review all the pictures, and many of the systems now have a preview option that allows you to look at multiple pictures so that you can select the ones that are most appropriate for your measurements. So here we have this wonderful case with multiple pictures. Which one would you select to make a measurement? Well, the answer is neither one, because they are all very, very poor quality. However, in this patient, contrast was given. And in some patients like this one, when one gives contrast, it's like turning the lights on. You see now beautiful pictures of the left ventricle in multiple views, allowing us to estimate or subjectively evaluate. It looks like a hyperdynamic heart, but also make measurements. Here is one apical view. It would be very easy to stop this image and trace and do measurements. But also look at the detail that we can see. This patient has hypertrophy at the apex with obstruction of the apex right here, and we have a little piece of the apex here that is not contracting very well. So going back to measurements, simple linear measurements are still done, reported every day, and used to make assessment of chamber structure and size and so on. For many years, we did this with end mode. But as this picture from the ASC document shows, even when you have a beautiful, beautiful end mode to make measurements, the end mode plane might come in like this, so that this dimension actually is a little bigger than the true dimension, because these patients, the long axis is pointing up a little bit. And this happens frequently as the transducer is placed a little bit lower in the apex, which is not done because you don't know what you're doing. It's done because often that is the best view that is obtained. So not uncommonly, we have this situation. The long axis is pointing up. And if you were to do an M1 measurement, you would get larger values than the real end diastolic dimension, which is along this particular plane, perpendicular to the long axis of the left ventricle. So for that reason, the document now recommends primarily to do measurements from the 2D unless you have an absolutely perfectly placed end mode axis. So these measurements vary between men and women, and they vary with size. So notice that a real big football player with a body surface area of 2.5, 2.6 could have an end diastolic dimension as big as 6 centimeters. Likewise, in a woman, a big lady, would have dimensions of 5.5, 5.6. So women have smaller hearts than men, but in both of them, the dimensions are linearly, directly related to the body size, and we still use body surface area as the way to index. There's been some debate whether one should use height or some other form of correction, because of some people are small in height but have a lot of obesity, which does give you a large body surface area. So here you have two examples, normal heart and a bad heart. The normal heart, you look at it very quickly, you can see it's normal. It has a very good shortening of the cavity. Ejection fraction is perfectly normal, probably even a little high. The other one, even with little training, you can see that it looks big, and the overall shortening of the cavity is reduced, and clearly this is an abnormal heart. Ejection fraction, well, it could be in the high 20s, in the low 30s, but clearly this is depressed, and in this particular case, the posterior wall is akinetic. So at the extremes, most people can easily assess that, even with minimal training. The problem comes that when not all cases are the extreme. So you show this patient, for example, which I have shown in many courses in the past, and ask the audience to give an estimate. And most people estimate using their eye is processing several things. The shortening fraction of the cavity, you sort of get a sense for how well that cavity is shortening. You can actually do a dimensional shortening fraction. In other words, in your own mind, you can do a fractional shortening of these diameters here. In fact, many years ago, we published a method for ejection fraction calculation using diameters. You can also use the descent of the base, because as ejection fraction drops, the longitudinal axis reduces and you have very poor descent of the base. However, this is often what I got when I showed this case to a big audience with audience response system. I got a spectrum all the way from some people voting for 60, some people for 20s or 30s, and most people within 40 and 50. This particular patient had an EF of around 43%. But the point is that the eye estimation can be extremely variable, and you really need to be a good expert to do a good job at estimating. And that's the reason why today, with all the good technology we have, we're truly emphasizing quantitation of volumes and ejection fraction. The two-dimensional method that the ASE recommends is the biplane summation of discs, where one traces the cavities in fore and two chamber, diastole and systole, and the computer produces multiple little discs, and then summates, look at the volume in each of these discs and put them all together through a very complex formula. But computers love formulas, and they can do this very quickly. So the key in getting good volumes with this method is first having good imaging. Notice that the fore chamber and two chamber are both pointing up to the transducer, and then tracing properly. And notice that when we are tracing, the tracing is actually excluding some of this trabeculation here. We learned this when we started doing contrast and started doing comparisons with CMR. We realized that it was more accurate to trace out and ignore some of these trabeculations inside the cavity. One good trick is to use an internal control, and a very good internal control is stroke volume by Doppler. So in the absence of mitral regurgitation, stroke volume by 2D should be within 5 cc's of stroke volume by Doppler. And that can give you a sense of your accuracy. Now look at this heart. This is a big heart with body F, but notice how, with contrast, the heart looks a little bigger than here, and the EF doesn't look quite as good as it did without contrast, even though the image without contrast was not a very bad quality image, it was a decent image. And this is exactly what this group of investigators reported back in 2001 from the Mayo Clinic. They used EBCT as a gold standard, and notice that when contrast was given, not only was the correlation better, but now the line of identity was very close. The regression equation was very close to the line of identity. Without contrast, the volumes were very much smaller than with contrast. So contrast allowed for the volumes to get bigger and therefore be more in agreement with the EBCT standard. In the ASE document, you will find multiple tables that will give you normal values. In fact, in this one, you can see the normal range, what is a mildly, moderate, or severely enlarged diameter or enlarged ventricle by volume. So most labs now have these tables put in a place where everybody can see them, and you can use them in your report. So three-dimensional echocardiography have been around now for at least a decade. Initially, the 3D technology was a little bit more primitive, and one had to stitch 4 bits together. So this was the representation of 4 bits, which was good if you have a regular heart rate, but it could be a problem if you have irregularities. Then one had to manually make some corrections on the planes so that you would eventually end up with a 3D rendered image. And then the computer would take over, make the calculations, and report the volumes to you with end-diastolic and systolic, stroke volume, and EF. And when done well, the values were accurate and relatively easy to get. This is a process that would take a minute or two. In a multi-center study back in 2008, this technology was validated against CMR. And the correlations were pretty good, as you can see, for end-diastole and systole, EF, and so on. But notice, again, that when end-diastolic volume by MRI, CMR, was around 300, by 2D, it was more around 200. So still, there was this tendency to foreshorten and to have smaller volumes calculated compared to the standard of CMR. And then for ejection fraction, although again correlation was excellent, you still have outliers. In this situation, there were 5 really bad outliers. Here we have one person with 65% by CMR, and gee whiz, 20-something by 3D. This group here has EF in the 50 to 60 by 3D and in the 40s by CMR. So individually, you would have outliers, which becomes an issue as we will discuss in a minute. Now, today we have really fast processing computers that have given us the opportunity now, to measure volumes on a single bit without having to do a stitching of several bits. So now one can do ventricular volumes, integrating multiple views. Here you see the results that come out. And even now atrial volumes, which is a subject for another talk. This is one of the validation studies where, again, you can see very nice correlations with CMR, but the same tendency. A 200 cc end-diastolic volume by CMR was more like 150 by 3D. So again, we have always this tendency to report lower values compared to CMR. Ejection fraction was not bad. Pretty good correlation here and tight in this particular study. And the beauty of this technology, as it keeps progressing, is that we are beginning to be able to do actual volume curves on a beat-to-beat basis. And now we can study the influence of arrhythmia on volumes and ejection fraction. Here is an example from a publication by Nolan of atrial fibrillation. Very rapid heart rate, and you can see the impact of the variations in diastolic and systolic volumes. So this is a wonderful technology. As it becomes more and more widely available, it's going to really help. And now this technology is even being applied towards smaller systems, even some of the handheld systems. So let's talk a little bit about hypertrophy. Why do we care about hypertrophy? Well, the first thing is that hypertrophy has a negative impact on prognosis. A lot of studies have been shown, particularly with hypertension. Hypertrophy is associated with diastolic dysfunction and ultimately may lead to heart failure. Now, hypertrophy is not wall thickness. Hypertrophy is left ventricular mass. And we know that we have concentric hypertrophy, where the LV has a normal cavity size with increased thickness, and eccentric hypertrophy, where the ventricle is dilated. The thickness may not be significantly increased, but the combination of a dilated cavity and the wall thickness produces an increased mass. This type of hypertrophy is called eccentric. Now, there is a kind of a complicated 2D method to derive LV mass, which integrates the short axis and the apical views, 4-chamber, requires extremely good quality images. And right now, it's not truly widely used in most labs. It's kind of still more of a research tool. So in the ASC document, believe it or not, they still recommend the traditional linear equation, which was developed in the days of ENMOD, where basically one used the diastolic dimension and the combination of wall thickness from the septum and posterior wall, and we used the cube equation to develop LV mass. So on the document, what they did is they validated that this equation can also be applied with measurements from to D instead of from N mode. So you get the LV mass as long as you are measuring a representative thickness. So when you have equal thickness across, this works well. However, if you have a lot of asymmetric thickening, for example, the base of the septum being thicker than the rest, you can have some problems. In addition, the system can give you relative wall thickness, which is basically radius cavity thickness radius ratio, or the same thing as the sum of the septal and posterior wall thickness divided by the end-diastolic dimension. So this is the relative wall thickness, which is increased with concentric LVH, but preserved with eccentric LVH. So when you do this, you can report in your echo report if there is hypertrophy or not by giving mass values. Here are the LV mass ranges using this linear method. For a woman, the upper limit is 95 grams per meter squared. This is corrected for BSA. And for a man is 115. And then the relative wall thickness, which is 0.42 for both sexes, so that you can determine if somebody has concentric remodeling, i.e. the relative wall thickness is increased, but the mass is normal. If they have concentric hypertrophy, which is both increased, normal geometry, or eccentric hypertrophy. And nowadays, we routinely put this in our report. In addition, the document provides the numbers to allow you to qualify your measurements and say whether somebody has mild, moderate, or severe hypertrophy, both for men and for women. And again, these are tables that are often placed in the echo lab. So if we summarize what we have discussed so far, the first step is to select an optimal click for best measurements. Absolutely. That is number one. Practice makes perfect. The more you measure, the better you are going to get. If we use 3D, then we need to recognize that 3D volumes and EF, although they are becoming more automated, single bit, and more accurate when you get all the right ingredients of good quality images and so on, the limitation is that you still need pretty decent quality images, and contrast cannot be used. Right now, the systems get confused when you put contrast. And the problem that we have is the challenge of resolving a disagreement between a 3D value and a visual estimation. You remember the slide I showed you from the multi-center study versus CMR, there were 5 patients with wide disagreements. So if your eye is telling you something different than the value reported and your eye is experienced, which way do you go? Personally, I still go with the eye, or I do a manual measurement with the conventional method. Quite often, if you have experience, your manual measurement using the ASE method and your eye tend to agree fairly well, and that may be another way to resolve a disagreement that you perceive between the 3D value and your eye. The problem is that in experienced laboratory might trust the 3D too much and report a 3D value which could be erroneous. So those are the things that we still have to keep in mind. Now, let's talk a little bit about regional wall motion, which is part of ventricular function. Here we have 2 nice examples. This patient here has clearly global dysfunction and EF that is in the 30s. There is diffuse hypokinesis. However, this area of the inferior wall is clearly akinetic. So there is some regional abnormality in the face of a global dysfunction. This other patient has an EF of 54% and has pretty good contraction in many areas. However, clearly we can see the apex is not coming in and looks like it's akinetic. So these are 2 examples of regional wall motion. Of course, there are multiple examples of regional wall motion. And the only way you can learn this well is by reading echoes next to an expert that guides you through the development of your eye to be able to estimate this well. Because as of today, still the eye is the way that we do most of the regional wall motion assessment. And this is an old diagram from the segmentation of the LV, which used to be 16, but after the echocardiographers, the nuclear cardiologists, and the MRI and CT people got together, they came into agreement to have a 17 segment, which basically meant that the tip of the apex became a segment by itself. These are the 17 segments, and by color you see the distribution of LAD versus circumflex or RCA. And this is something that most fellows learned very quickly after a week or two in the echo lab. Now, the way to semi-quantify this is to assign a score value to the wall motion. So normal is 1, this kinetic is 4, kinetic is 3, hypo is 2, and aneurysmal is 5. You give that to each segment, and you add them all up and divide by 17. So that a normal wall motion score index would be an index of 1. An index of 2, for example, would mean that there's a fair amount of abnormalities in multiple segments. And the reason why it's important to report this, which we do routinely in our lab, is that there's many, many studies done in the 80s showing that the wall motion score index by itself also had prognostic value in terms of predicting heart failure and mortality. So everybody wants to have an ejection fraction, from a surgeon to cardiologists to internists to neurologists to orthopedic surgeons. Everybody wants an EF. And although we have been talking about better ways to get an EF, we need to also recognize that there are some limitations of ejection fraction. First of all, there's some measurement variabilities. We know that well, and the least variability is seen with CMR. EF is influenced directly by preload and inversely by afterload. It's very load dependent. And I think that is the most important limitation that it has. Now, it's a measurement of the pump function of the heart. The heart pumping. Not a measurement of the myocardial function. And perhaps because of this, we have seen variable outcomes in a range of EF. This is a figure taken from an article by Potter, a review article, and you can see here that once EF goes under 30%, yeah, the mortality goes up, but within this range of 35 to even 60, you have a wide range of mortality, and the reason for that is HFpEF, heart failure with preserved EF, which is a disease that we know has almost as bad an outcome as HFrEF, and yet these patients may have perfectly normal EF. Same thing can be seen with some valvular diseases and some of the hypertrophic diseases. So EF does not always give you the full story when it comes to assessing the severity of the left ventricular dysfunction and possible prediction of outcomes. So nowadays we have strain imaging. Strain imaging started first with tissue Doppler, but nowadays the way to do it is by speckle tracking. And what is speckle tracking? Well, remember that echocardiography now is all fully digital. The images are in a digital matrix where you have pixels. And the computer then can take a pixel and follow its course from diastole to systole. So if this is a little pixel, this pixel has been tracked from diastole to systole. This other one was tracked too, and then you can see the linear measurement of those two, how it changed from diastole to systole. So now we can look at multiple pixels and see the degree of deformation or shortening that occurs from diastole to systole. And if you divide that measurement by the diastolic measurement, you have a percent change, which is strain, the percent shortening or change in that dimension. So today's instruments can do speckle tracking and derive strain in 3 different axes. Radial strain, which is a vector coming into the center of the cavity, which in essence gives you an assessment of segmental myocardial thickening. Circumferential strain, which is a vector along the circumference of that cavity in a short axis view, and the longitudinal strain, which is a measurement of segmental myocardial longitudinal shortening along this axis. A lot of publications are out there that you can review, and although all three of them have been applied, as of today, longitudinal strain is being used more because it has shown better prediction of outcomes. That's the main reason that you're going to see more publications with it than with circumferential or radial, but there's still a lot of work being done in all three of them. And actually, the integration of all of that into looking at ventricular torsion, which is how the ventricle contracts and rotates from apex to base, which is a wonderful way of evaluating a ventricular function. Right now, still in a research form, not necessarily have found yet much clinical application, so I'm not going to discuss it today. So this is a normal heart. You can see the short axis and the apical fourth chamber. And this is longitudinal strain from the apical fourth chamber being measured at 1, 2, 3, 4, 5, 6 places. And notice that the curves are all pretty much going together. Looks almost like a volume curve from diastole to systole. This is just a color display that allows you to see that everything appears fairly homogeneous. And this is a normal patient. Now, if you take 3 apical views, 4 chamber, 2 chamber, and apical long axis, and integrate them, you get the entire ventricle, and you can put all the values of all these segments into a bullseye. Apex here, spreading towards the base, septum, anterior wall, lateral, inferolateral, and inferior. And you can add all these together, and this would be your peak. This would be the peak longitudinal strain in all of these views. So this bullseye, at the end, when you summate all that and average it, is the average peak global longitudinal strain. In this patient is minus 21%. However, from here on, I'm going to eliminate the sign because it can be confusing and just use 21%, because 14% is worse than 21%. And from a negative point of view, it's a higher value, but from a clinical point of view, it's a worse value. So let's get rid of the sign and let's just use the number. So here we have a bad heart. Clearly, globally, is abnormal. EF is bad. But notice that when strain is used, first of all, the color display shows a real mess here because there is a lot of heterogeneity, which we see in the curves. You still have contraction in some segments, very poor in others, and actually a certain amount of dyskinesis in this particular segment. So there is heterogeneity of contraction or regionality, even though it's a very global heart. And this could be a non-ischemic cardiomyopathy. Just because we see this, it doesn't mean it has to be coronary artery disease. What's normal? So a lot of work has been done, and a lot of publications came out with normal values. There's variation between companies, machines X versus machine Y. So all of this has been put together, and people have done meta-analysis, and the bottom line is that most normals are between 15.9 and 20-something. So that in our lab, we have taken the position that anything over 17% is normal, under 16% is reduced, and between 16 and 17, we use the term low normal to give a sense. Remembering that strain, as any systolic measurement of myocardial function, is load dependent. So therefore, you may see variations in the same patients because of differences in blood pressure, and that's one of the recommendations of these articles, are to always have blood pressure available and reported with the study. So a patient today might be 17.2 with a blood pressure of 200, and a month from now might be 18.4 because the blood pressure was 120 with therapy. So there is some variability, and that's one thing to keep in mind. So what do we do with this? How we use it? Well, the basic use today is because that strain, being a myocardial function parameter rather than a LV pump function parameter, allows us to detect subclinical dysfunction of the myocardium in a variety of diseases. Subclinical means A, patient may be asymptomatic, B, ejection fraction may be normal, and is appearing to be a better predictor of serious cardiovascular outcomes in certain group of patients. In addition, it gives us an objective assessment of regional function that we can use both in coronary artery disease and also with different types of myocardial diseases. So here we have this hypertensive guy that has a severe concentric LVH. Look at the size of the left atrium, it's pretty big, but have an ejection fraction of 90%. I mean, this is a cavity obliteration type of a heart. And yet, the average peak GLS is 14.2. It's reduced. And notice also that there are some areas that is severely reduced. There is some regionality to this, okay, despite a superb ejection fraction. So, question, is GLS a better predictor of outcome than LVH in hypertension? We don't know. Stay tuned. This is being studied by multiple labs. There's been some publications already suggesting that it may be, but I think we need more data to know, and perhaps where it's going to be of value is in the hypertensive patients that does not have much LVH, if they do have a depressed GLS. That may be a subgroup that we may be able to pick up, because I think the data with LVH is very powerful. Once you have significant LVH, outcome is pretty bad. Now, even in that group, it could be that a GLS of 9 could have a worse outcome than a GLS of 12 in that subgroup of patients. We don't know. Stay tuned. But I think it's one of the areas of great interest. So applications, as I said earlier, is detection of subclinical dysfunction, and there is a long list here which is growing of more and more reports. Hypertensives, hypertrophic cardiomyopathy, diabetics, transplant rejection, chemotherapy toxicity is a topic by itself, and there will be a lecture on this later in the year. Valvular lesions, sepsis even, acutely, and heart failure with preserved EF. This is a big one, and this may be one of the big areas where strain may come to help, because clinical outcomes appear to be worse in those patients that had a bad strain. And this was a nice review that was done by Potter in 2018. They looked at a large sample size from the literature, and basically what they found was that here is ejection fraction from less than 35% all the way to better than 53. But within all these subgroups of EF, there were patients that had a variability in their strain. Even with normal EF, some people have strains that were reduced. Some of them reduced to very low levels. And within low EF, there were some patients that had kind of better strains than others, so that there was a more wide distribution of average peak global strain than EF. And the worse the strain, the worse the outcome. This was shown very nicely in this study by Park. Over 4,000 patients, 5-year mortality. A lot of these patients have HFpEF. And notice that EF didn't do much of a good job for prediction of mortality. This is probability of death. Look at strain. Once you went below 12, 11, or 10, big jump in 5-year mortality. Very, very powerful study, in part because of a very large sample size. This is a study more recent with aortic stenosis showing that patients that had a reduced GLS under 18% had a faster development of symptoms, and for that same reason, a faster need for aortic valve replacement. So should this one day become one of the criteria we may use for an earlier valve replacement in aortic stenosis? Stay tuned. Mitral regurg, same story. In this study by Mentias, they follow people for 12 years. And regardless of whether they were treated medically or got surgery, the point was that those that had a strain below the median of 21.7 over time had a worse cumulative proportion of death. So as we learn more about these findings in valvular heart diseases, it may be that the guidelines may be altered, may be altered in terms of decision making for interventions. So How to use global longitudinal strain? Well, it is an index of myocardial fiber shortening, and thus is also induced by loading conditions. Always keep that in mind. Unfortunately, inaccurate results, which usually are because of poor image quality, they may be incorrectly accepted. And then question is, how does one know that an abnormal result in an individual patient that has otherwise a good EF, no hypertrophy, the echo looks kind of okay, is it really abnormal or not? So when do we report an abnormal value if everything else looks great? The 2D echo looks absolutely normal. Personally, if the images are of good quality, I still report it because we are learning more and more about what that may imply. Now, you may have to put a caveat sentence there that it's a mild reduction, because most of the time these are mild reductions, and we still don't have much data, much knowledge about it. But if we don't put in the report, we won't be able to learn. However, if I have any concern with the image quality in any way, I will not report it. Now, the next dilemma is, how do we treat an asymptomatic patient that has a normal EF but an abnormal GLS? What do we do with that patient? If it's a hypertensive, do we treat them differently? If you have somebody with heart failure and they have a very low GLS, do we alter what we do? Do we take a heart failure patient with an EF of 25% that has a GLS of 6, very poor, and maybe push them faster to our advanced therapies? We don't know. I think prospective studies are needed to help us decide the therapeutic impact of this measurement. How will it change what we do? If we have a patient with aortic stenosis, would we replace the valve sooner because the GLS is reduced? Same thing for mitral regurg. So all of these questions will need to be answered by prospective studies. Now, here we have a little bit of regional one motion. You saw that 2D echo before. The patient that had a global dysfunction, in fact, EF was 38 with an akinetic septum. And you have now an average peak global GLS of 10%. But look at all the severe levels of abnormality that are reflected, consistent with what our eye was seeing right here, and here too. So very nice relation to the eye estimation, but giving us a very nice polar map of the distribution of the really low values of GLS. This is one that is more subtle. This patient has a decent EF, and we could argue whether this inferior wall is abnormal or not. Maybe there's a little bit of foreshortening, but the GLS is very, very impressive. Pretty good values here, but very low values, minus 3% down here. Really consistent with a true wall motion abnormalities. The average global GLS was 13%. This patient did have an RCA lesion. This is the patient you saw before also with the apical abnormality. And the average GLS was 12.5 despite an EF of about 54%. You have some low values around here, but you have a dense area of very poor values of 1%, 5%, reflecting that area of the apex that is akinetic. As exciting as this look, I have to tell you that the use of this technology with stress echo is still challenging. And with exercise, it's very hard, and we're still struggling to make this work, because it would be nice if it did. It would be one way of making stress echo a little bit more objective and away from the eye. But again, stay tuned. Now, here we have a patient with amyloidosis, actually severe amyloidosis. The ejection fraction is already depressed, severe increased wall thickness, small pericardial effusion, very bad GLS. I mean, the average is terrible. The average is about 7%. But the apex is spared. This is what is called apical sparing, which is not 100% specific for amyloid, but should make you think of amyloid when you see, at the same time, you see findings like this. Interesting patient that we had recently is a 79-year-old lady, came in with chest pain, and this was the echo that was done. And as you can see, there is a hyperdynamic LV, but we don't see much of what's happening around here. When the strain is done, the average strain was 11.4, which is reduced. However, there is again this very dense area at the apex of very poor values. So contrast was used, and when contrast was used, you can see very nicely that there is that the patient had apical hypertrophic cardiomyopathy with obstruction right here, and an area here probably with a very high ventricular pressure, and the tip of the apex not contracting well, also shown very nicely by CMR, and showed very nicely by strain. You had that really dense area at the tip of the apex that had very, very poor values. So in summary, regional strain this is for regional strain, may help in detecting regional abnormalities in patients with CAD, but also in non-CAD patients that have either non-ischemic cardiomyopathy or other types of cardiomyopathies. Use with stress is still limited. And these regional abnormalities that can be seen in patients with reduced global longitudinal strain. So you have the combination of people that have some reduction in global findings and also have regionality. And the strain is able to give us this information much better. How do we use it clinically? Right now it's mostly diagnostic. I'd like to finish another 5 minutes or so with some of the new exciting things that are coming along. Automated quantification, machine learning, artificial intelligence. This is helping us guide a health provider through image acquisition, a nurse, a technician, somebody who is not a sonographer. There is automatization of measurements and interpretation, and combining echo findings with EMR data for outcome predictions, and I'll just show you a little bit of that. This is a study by Nolan, or a review paper by Nolan, showing very nicely all the areas where automated quantification is coming around in echocardiography, not just volumes and EF, but left atrial volumes, right atrial volumes, left ventricular mass, Doppler findings, automated assessment of stroke volume by color Doppler, aortic root measurements. So a lot of quantification that is becoming automatic because of machine learning and artificial intelligence. As the machine learns from an experienced sonographer, it can then guide an inexperienced health provider through the process of acquiring the images. And then, as shown in this paper by Zhang, these images now can be automatically interpreted by the system with the AI and look at all kinds of different areas and produce a report. And as an example, in this article, they show you the ROC curve for accuracy in detecting hypertrophic cardiomyopathy, cardiac amyloidosis, pulmonary hypertension. So this is actually still in its infancy. And the future could be applying these technologies with demographic and EMR data, all these measurements and information from the echo into a prediction of outcome. And in this paper by Zamat, they look at over 170,000 patients, not 10 or 15, a huge number of patients, and apply the technology. And they could see that in all patients, machine learning with echo measurements and using data from the EMR had an ROC of 0.89 for prediction of mortality in 5 years. That's very impressive, very impressive. So now we have handheld systems. If these handheld systems are helped by artificial intelligence so that a nurse can even get some data, or an internist, and this data is processed with automated interpretation and linked to the EMR data, an outcome prediction could come out. For instance, this is a patient I saw recently in our community clinic with a cardiomyopathy. We were using a handheld device. You can see a poor EF and some mitral regurg. This could have, in the future, could be part of all of this conglomerate of data analysis, and the system could spit out telling me that the 5-year mortality may be 22% if I don't do anything, but if I do optimal therapy, it could be 14. I might even recommend to me what that optimal therapy might be. So this is an amazing future that we are looking at, And as you can see from some of the papers that I show you, already part of this future is here. It's just a matter of making it more widely available, making something that that everybody can do. We will eventually be training medical students in using handheld devices and so on. So I thank you very much for your attention, and we're going to have some time for questions. And hopefully we will have some questions come up. Just again to remind you, if you have any questions, just text DeBakey to 37607 and then text your question. Or if you are in the internet, just go to POLLEV.com, enter DeBakey, respond to the activity, and send us a question. Well, it appears that everything was so clear, no one has any questions. So if that's the case, I thank you very much for your attention, and this lecture does remain in our archives that you can easily find it through YouTube, so our YouTube educational channel. Have a great day. Okay.